afternoon and welcome to the launch of the consultation on the Scottish Injecting Equipment Provision Guidelines. I'm Jim Shanley. I'm the manager of the harm reduction team for NHS Lothian, and I'm also the co-chair of the IEP guidance group alongside John Campbell from Greater Glasgow and Clyde. So I'd like to say, first of all, thanks to the National Expert Guidance Group for all the hard work, the meetings and the examination of research and literature worldwide, which created the document we now have. It was a huge commitment, and I can tell you that we were making enormous progress until COVID came along in March last year. So we were almost at the point of consultation in early 2020, when of course priorities changed for all of us. Can I also take the opportunity to thank Alex Sanchez from Public Health Scotland, who supported the group and helped us formulate the research information and demonstrated a personal investment in the process of updating the 2010 national guidelines. Today, it feels like a huge step forward in the consultation process, and I'm really pleased to welcome you to this webinar hosted by SDF. So a big thanks to them also. You will hopefully have seen a copy of the document, and I appreciate that it's a very lengthy document demonstrating the work that has gone into it. However, we really welcome your thoughts, especially in the light of the recent scrutiny around national drug deaths and the need for all of us to prevent harm and promote safer practice whenever and wherever possible. So we will hear from three speakers today, Dr. Andrew McAuley of Public Health Scotland, Glasgow Caledonian University, and co-chair of the Scottish Sexual Health and Bloodborne Virus Prevention Group. He will be discussing epidemiology and the impact of IEP. Secondly, John Campbell, co-chair of the Expert IEP Guidance Group at NHS Greater Glasgow and Clyde, who will be talking about current trends in injecting and injuries. And last but not least, Dr. Magdalena Harris, Associate Professor at the London School of Tropical Medicine, who will be presenting on the ancillary benefits of IEP and the provision of sterile inhalant pipes. We'll hear from each speaker in turn, and then we'll have a question and answer session at the end. Obviously, you're encouraged to submit your questions throughout the whole of the webinar. The question tab appears on the control panel, which should be at the right-hand side of your screen. Leon Wiley, who's the lead officer at Hepatitis Scotland, will join us for the discussion session at the end of the presentations. Well, he'll summarise the questions and present them to the panel. So that's my introduction. Welcome everyone, and I think we're about to start. If I can welcome Andy McAuley. Hi, Andy.
Hi, Jim.
Hello. So, Andy, I'll let you kick off, and I'll come back in and rejoin you in about 15 minutes' time.
Thanks, Jim. That's much appreciated. So, afternoon, everyone. I think my role today is really to bring people up to speed on the epidemiology and the impact of IEP, particularly the trends we've seen in the areas that we would expect IEP to have an impact on, and the trends we've witnessed over the last decade since the last IEP guidelines were published. Next slide, please. So it's important to remind us all about why we're here in the context of that. We know that people who inject drugs are at risk of a range of health harms, including bloodborne viruses, bacterial infections, but also in relation to overdose and drug-related deaths. And there is a large body of evidence to support the effectiveness of the provision of injecting equipment through IEP services to reduce injection risk behaviours that can lead to these harms and other drug-related problems. But IEP shouldn't be viewed ever in isolation. It should be viewed as part of a broad range of interventions, and evidence certainly tells us that IEP is most effective when delivered in combination with these other harm reduction interventions, such as medication-assisted treatment, and bloodborne virus testing and treatment. Next slide, please. It's also important to remind yourself what an IEP intervention is. Traditionally, people have associated injecting equipment provision services or needle exchanges in the more traditional sense as merely providing needles and syringes. But we've come a long way from that more basic interpretation of IEP over the last 20 years, and particularly over the last 10 years, where IEP services have really evolved into specialist harm reduction centres, offering a range of different care and intervention for the service users. And this includes provision of injected equipment, of course, but also provision of advice on safer injecting, on wound care, and also extending the range of services available on site. In some areas, bloodborne virus testing is not just signposted, it's actually available on site, as is provision of drugs like Naloxone. Next slide, please. So just to kick off in terms of the epidemiology, thought it was worth focusing on injecting risk behaviours. And next slide, please. And first of all, really to look at drug trends. Now that we could probably spend a whole presentation looking at drug trends, but we are mainly concerned with people who inject drugs. Obviously, other service users use IEP as well, but I wanted to pick out this particular trend that has really changed since the last guidelines were published in 2010, and it's really in relation to the injection of stimulants. Now, the vast majority of people who inject drugs continue to inject heroin, of course, and that should not be forgotten in these conversations and should be an absolute priority for our work. But we've seen a huge shift towards the injection of stimulants, mainly cocaine, in Scotland over the last 5 or 6 years. This trend towards the injection of stimulants is not unique to Scotland. We see it in England in relation to crack, and we see it in parts of Europe as well, particularly in relation to stimulant-based NPS. But in Scotland, powder cocaine is very much a drug of concern at the moment in terms of the proliferation of its injecting amongst the community. And you can see here around a third of people we interviewed in 2019-20 during the NESI studies reported injecting cocaine. And these estimates are much higher in different parts of the country. For example, in West Central Scotland, these estimates will be over 50%. And in some areas, cocaine injecting is as common as heroin injecting is. We should also point out, although not covered in these slides, the rise in the injection of imaging performance enhancing drugs, which has also been a key change over the last decade in terms of the utilisation of IEP services by people who use those drugs. Next slide, please. And the reason I've kind of picked out cocaine particularly here is because of the role it's played in drug-related harms over the past few years in Scotland. I mean, first of all, people who are injecting cocaine are really injecting it in isolation, so it increases polydrug toxicity. This is typically people who have traditionally injected heroin and other drugs are now adding cocaine into that daily routine. So we've seen a rise in cocaine-related deaths in recent years in Scotland, which has been fueled by this shift to cocaine injecting. We also know cocaine as a stimulant is known to be associated with an increased frequency of injecting and other risk behaviours such as equipment sharing and equipment reuse. And it also increases one's libido. So in combination, these factors can increase one's risk of bloodborne virus and sexually transmitted infections. And again, in recent years, we've seen cocaine identified as a main driver of the HIV outbreak in Glasgow, which is still ongoing at the moment. And also, cocaine affects treatment outcomes. There's good evidence to show that people who inject cocaine have poorer engagement with drug treatment services, particularly retention on OST. And we know that OST can be a protective factor, not just against drug-related deaths, but other drug-related harms. So it's very important we acknowledge this rise in cocaine, particularly when talking about IEP services that can play a key role in addressing it. Next slide, please. Also, in relation to injecting risk behaviours, it's not just the drugs people that have taken have changed, it's also in relation to the way they take those drugs. We have seen relatively stable trends in people reporting sharing of injecting equipment, although that tends to be quite a stigmatised question for individuals, and we acknowledge that may be an underestimate compared to what we know goes on in the community. We know that sharing of other equipment, spoons, filters and the like, has continually come down over the last decade. But one of the changes we've seen is the reuse of equipment has increased. The latest estimate was slightly down on the previous year, but overall across the decade we've seen reuse of equipment gradually increase, and we infer that this is linked to the rise in stimulant injecting, where the compulsion to reuse equipment is much higher than it would be with other drugs. And in the graph on the right is linked to the final bullet point here about adequate needle and syringe provision, and by adequate we mean that people have fresh equipment for every injection that they engage in. And unfortunately we've seen that kind of tail off in the last couple of years, which is a concern, because obviously to prevent drug-related harms, it's absolutely crucial that people have the right amount of equipment, and there are obviously a lot of factors playing into people's ability to achieve that, and it's something we must acknowledge moving forward as a sector to try and improve. The analysis on the right was done in relation to the HIV outbreak in Glasgow to see if there was any specific differences there in terms of coverage compared to the rest of the country, but you can see this downturn in coverage below the 70% mark, or on and around that, is pretty consistent across the country, and again something of concern moving forward. Next slide please. Now, bloodborne viruses are obviously one of the main outcomes associated with injecting, and one of the main outcomes that injecting equipment provision services are looking to prevent. Next slide please. And I thought we would start on a positive note here, and it's in relation to hepatitis C. This is the latest chart from the Shooting Up report, which was published just a couple of weeks ago by Public Health England. And you can see that we've made significant gains in reducing the prevalence of chronic hepatitis C virus in people who inject drugs, very much aligned to Scotland's target for Hep C elimination by 2024. And this has been achieved through significant advances in Hep C treatment, of course, but also in other hepatitis C prevention activity, which includes a significant role by IEP services themselves. And you can see that Scotland's pursuit of Hep C elimination, compared to our UK counterparts who are also doing well, I must add, but Scotland is very much at the front of that pursuit. Next slide, please. And as well as giving out injecting equipment for Hep C prevention, Hep C testing is absolutely crucial to that. And we can see here that Scotland has managed to consistently achieve increases in Hep C testing rates. This is people who have been recently tested for hepatitis C, so that's in the last 12 months. And you can see that's continually increased over the last decade. I should acknowledge here that these estimates were taken before the COVID pandemic hit. And it's realistic to assume that bloodborne virus testing will have taken quite a significant dent over the last 12 months, and we have work to do as a sector to get those rates back up to the baseline as to where they were before. But pre-COVID, things were certainly trending in the right direction. Next slide, please. As well as we've done in hepatitis C, and the path towards elimination looks to be fruitful at the moment, we have to acknowledge that new hepatitis C infections are occurring in our communities. We haven't seen a significant decline in hepatitis C incidence over the past 10 years. At the beginning of the decade, we did see declines in hepatitis C incidence, which were linked in studies to Scotland's Hep C strategy, and were very encouraging in terms of the figures, but we've seen over the past 5 or 6 years that incidence rate continue to kind of increase again, with many mitigating factors, again such as the onset of NPS, which we know is significantly associated with an increase in Hep C infections and Lothian in particular. And again, we've seen other changing trends in recent years impact this. So we shouldn't be complacent about hepatitis C despite the advances. Next slide, please. So the good news in hepatitis C is countered in some ways by the challenges presented in relation to HIV. Now, HIV prevalence amongst people who inject drugs at a UK level absolutely remains low, and is testament to the work people have done over the past 30 or 40 years. But unfortunately, it is increasing in Scotland. So we see rates remain below 1% in England, Wales, and Northern Ireland. And Scotland was in that position around 7 or 8 years ago, but that's significantly changed now. Our latest estimate around the country is around 4%, which is obviously considerably higher than we see in the other UK countries. Next slide, please. And the reason for that shouldn't be news to anyone. This should all be fairly well understood. It's the rise in HIV prevalence is driven by the outbreak in Glasgow City. And we've seen a tenfold rise in prevalence, particularly between 2013 and 2017, which is somewhat stabilised in the most recent estimates, but still creates a significant reservoir of infection in the city centre. And we know that transmissions are ongoing in 2020, particularly people who had recently been transmitted the virus. So there is still much work to be done there, despite a huge effort that's went in across the city in getting the prevalence rate to stabilise. Next slide, please. And one of the more concerning parts of the outbreak has really been the drift away from the city centre. It was very much a city centre outbreak for the first few years, but we now have evidence that there is transmission occurring out with the city centre, certainly in the outlying areas of Greater Glasgow and Clyde. And then now in our most recent data, we've got evidence of a drift of the HIV outbreak into neighbouring parts of NHS Lanarkshire. So this should serve as a warning call that we have to absolutely continue to prioritise HIV prevention as much as Hep C prevention. Next slide, please. And just to complete the look at HIV in relation to testing, so we looked at Hep C testing, which has continually increased over the years. HIV testing was on a different trajectory until recently for some areas. As you can see, pre-outbreak HIV testing among people who inject drugs in Glasgow was at the lower end of the scale nationally. If you follow the kind of red line here in Glasgow City, you can now see that thanks to the considerable effort of everybody involved in the outbreak management, HIV testing in Glasgow City is now at the high end of the Scottish estimates. But we still see the rest of the country still kind of really kind of lying around the 50% mark of people who've been tested for HIV in the last 12 months, which is too low and something we need to address as a priority to avoid a repeat of the Glasgow situation in other parts of the country. Next slide, please. And I just wanted to touch on skin and soft tissue infections because I think these are increasingly becoming an important role for IEP services to identify and address. And I just wanted to include a brief slide at the end here. So next slide, please. This is our general rates of skin and soft tissue infections. Unfortunately, like bloodborne viruses, we don't have a biomarker of this. This is kind of self-report. And we consistently see around 20 to 25% of people who inject drugs reporting having had a skin and soft tissue infection in the last 12 months. Now, this may be an underestimate in relation to what people identify a skin and soft tissue infection as, or people just not disclosing things. But even at that, this is still a significant minority of individuals, and these skin and soft tissue infections can often be quite severe for individuals and can lead to much more harmful complications further down the line if not identified early. And it's absolutely critical that IEP services identify these as a core part of their role alongside bloodborne virus and overdose prevention. Next slide, please. So just to finish off, to summarise, yes, absolutely, IEP is a key evidence-based harm reduction intervention, and it is most effective when implemented in combination with other harm reduction services. We shouldn't be I don't think we are anymore, but we should always remind ourselves we shouldn't be working in silos. And I think Scotland is done well in recent years to integrate the work of different harm reduction agencies together to achieve common goals. But drug use is changing and has been changing fairly rapidly over the past 5 or 6 years, certainly over the last decade. And IEP has to evolve at the same pace. Scotland has a good track record in doing this, particularly in terms of the range of equipment that's offered, bespoke solutions to different issues. And certainly new things are coming around the corner all the time, and we must evolve to keep up with them. And certainly the most recent application that Leon is leading on in terms of getting legal exemption to allow crack pipe distribution from IEP services is an example of the kind of ongoing work we're doing in this area. Progression towards Hep C elimination is great, but it must be balanced against the re-emergence of HIV transmission amongst this population. And it's important to acknowledge that IEP is critical to both agendas. And I think everybody here knows this, but it's always worth reminding people that IEP services are much more than BBV prevention and can help to reduce a range of harms amongst people who inject drugs, including skin and soft tissue infections and overdose. And I suppose last, just a picture, a bit of advocacy at the end, that the guidelines are essential to support IEP staff and their clients to achieve the best possible outcomes. And it's really great that the huge amount of work that's went into updating these guidelines is finally getting out for public consumption. Thanks.
Thanks, Andy. That was really, really interesting. I think the one thing that I just wanted to say was the information that we get from NESI, which allows us to look at a lot of those issues. And obviously and clearly, you've demonstrated there's a lot of great work that's been doing, that we've been doing in Scotland, and a lot of advances, but we know that there still remains challenges. So thanks very much for that. John, can I bring you in now for your part? Hi, John.
Absolutely. Hi, Jim. Thanks for that. Okay, I guess before I go into the main presentation, I wanted to say just a little bit also about the guidelines. I think the group felt it was really important that we produced not just a comprehensive set of guidelines, but also a useful working tool, if you like, for all areas across Scotland. You know, and a tool that will help areas improve the response when working with people that inject drugs, but also at an individual level for those frontline workers, something they can use to help improve the response and interventions as well for our target client group. So I hope when you see the documents, you look at them and read them with that in mind. Okay. Okay, the main part of my presentation will essentially be talking about findings of our assessment of injecting risk. The assessment of injecting risk was one initiative that was part of the One campaign. The One campaign we've had running in Greater Glasgow and Clyde since the 1st of September. And I guess where the One initiative came from was a lack of consistency in delivery of our core harm reduction interventions. We would often have drives on particular interventions such as the provision of naloxone or dry blood spot testing. So we would link in with services and, you know, highlight that the provision of naloxone wasn't as good as it could have been, so really encourage them to provide more. And that would be reasonably successful for a week or 2 weeks, and then we'd watch that start to drop off again. Now, bear in mind, in Glasgow, we're also living through an outbreak HIV. Dry blood spot testing for those individuals not currently engaging with services is vitally important. And it was the same picture there as well, where, you know, you would have a week or two where it was quite high level dry blood spot testing, and then it would fall off to very little. So we take a real look at this and think about how we could do things differently. And I guess what we come up with was we needed to drive footfall. You know, just relying on the services to maintain that motivation, you know, was always going to be a challenge. So how could we possibly encourage clients to want these interventions frequently? we certainly want, in relation to dry blood spot testing, people to be tested once every 3 months. We decided to incentivise it, and we incentivised it essentially cash. So, and we work with a Starbucks style reward card, I guess. So all the harm reduction services in Glasgow City Centre are involved in this. And they'll essentially tick off once you've completed one of the 4 interventions. 4 interventions are wound care. And by wound care, all we mean there is being able to check someone's injecting sites and assess the health of those injecting sites. The most comprehensive thing is the assessment of injecting risk. Provision of naloxone, all we want there is to check the client is actually carrying naloxone, and then providing dry blood spot test as well. Now, these are also linked into the NEO system. So every time someone completes one of those interventions, it's date stamped, if you like, on NEO. Once they've completed the 4, they're given a £20 cash voucher. They go to one of the dozens of outlets in the city centre, and they can exchange that for £20 cash. However, a lot of people have been taking cash. Other people have also been topping up their mobile phone, the utilities, buying some kind of basic shopping and things as well. So it's been really, really successful at driving footfall. I have to say, a lot of the services, felt a little bit overwhelmed at the start as well. Where they maybe had 10 or 20 people turning up, and looking to go through these interventions. Okay. Okay, so the assessment of injecting risk was a tool that was developed and refined by the National NEO Development Group. So all areas in Scotland were represented on this group. It's where we planned a national NEO system, and we refined this assessment of injecting risk. We're keen to see any other comprehensive assessments of injection risk that were available in the UK, and bizarrely there really weren't any. There were a lot of kind of baseline assessments or very, very loose assessments of injection risk, but nothing that went into depth about batch preparation or what are choices for preparing drugs. So we put together this, and then we piloted it, and then we made it available through the NEO platform. So this is a tool that's available across the country. It's very easy to use. It's got smart logic built in. So if depending on the answer the client gives you, it jumps to the next section. And it's also colour coded as well. And it's designed to take the member of staff and the individual through the assessment process. I'll give you a wee screenshot in just a wee second. But essentially what we're trying to do is normalise actually sitting and talking to someone in depth about their injection. We're trying to normalise someone presenting once every 3 months, to access a blood test. And we're also trying to normalise it from the staff's point of view as well, where they become far more comfortable and sitting talking to people about their injection. And you can see there the full range of areas or topics that are covered within that assessment. Okay. So that's just a screenshot there, and hopefully you can see how that's colour coded as well. And I was talking about the kind of smart logic that's built in. So for example, you can see they were asking about injecting locations. So if a person says they're injecting intravenously into their hands, when they tick that box, another drop down will pop up and it'll ask for the size of needle. So we're able to influence people's needle choices as well. And you can see the colour coding there relates to the lowest risk site, medium risk sites, and high risk sites as well. So you have an opportunity through the colour coding to identify the high risk sites, and the information at the top essentially guides the member of staff on what they should be discussing with the client. It also looks at things like areas where the drugs are prepared for injection, and it asks, if they select it's a public injecting site, for example, it then asks how safe that is, if it's exposed to the elements, if it's warm, all things that make injecting hurried and make it difficult to raise a vein, for example, they're identifying through this. Okay. So as I say, it started in September. We now have completed over 600 assessments of injecting risk. What I'm going to talk to you about just now is 377 that we completed in September. And we're very lucky to have Andy McAuley's team actually validate the data for us and clean it a bit and present it back to us. And I think these findings certainly show the harms that people who inject drugs in Glasgow are experiencing. I would be surprised if this wasn't common across the country. And if we're able to agree on that, then we should be able to agree on a national response for this. Okay. Okay, no surprises when you look at the main drugs that are injected, particularly after Andy had highlighted this. Main drug to make heroin, you can see there 77%, 53% injecting cocaine, and there was real crossover there. So we are for the first time identifying cocaine only injecting population, but the vast majority are also injecting heroin at this point. But if we're looking to identify overdose risks, then we need to know about other drugs that people are using. And you look at all the street drugs people are using, probably no surprise, but over 40% are using street benzodiazepines. Alcohol was common, over 18%. Something that surprised us was the use of street pregabalin, so that's out with normal prescriptions. So, you know, there's now a market in Glasgow for that. Nearly 11% smoking crack cocaine, and that's significant as we really don't provide or aim or target any services at people that smoking crack cocaine, so we really need to get our act together surrounding that. And also, as we've known for a long time, there's a market for street methadone as well. You can see almost 40% of people, in addition to that, were prescribed methadone, another 12% prescribed pregabalin as well. And it's interesting because this just mirrors, you know, toxicology in relation to drug-related deaths as well. Okay. We look at the sites people are injecting into multiple veins was common, and I guess that makes sense as, you know, the majority of people we assessed were at one point preparing and injecting their drugs in public places or outdoors, you know, where if you're finding it really difficult to access a vein because of poor light, because it's really cold, and the femoral vein may be a preferred target just for convenience. So we can see the majority of people, nearly 54%, injecting into their arms, but over 42% using a high-risk site like the femoral vein, and another 14%, you know, using another high-risk site like the legs. Yeah, and we've asked people where they prepared and injected their drugs. The single largest location, if you like, was at home, but there were more injections, if you like, taking place away from home and all these other locations as well. So it was really useful for us to see that evidence. Okay. Okay, something interesting happened here when we asked people to self-report any injecting-related complications ever. We were surprised to see so many people actually come back and say, well, they hadn't really experienced any injecting-related complications. But part of the assessment injecting risks involves physically checking the person's injecting sites and recording if they're in good health or poor health. And with those visual checkings injecting sites, we could see significant harm was being caused, whether that was ulceration, whether that was abscesses or cellulitis. And I think this is a real issue. I think a lot of people who inject street drugs, you know, are not necessarily aware when an injecting-related complication is there. They possibly think that swelling and pain and redness is to be expected if you're injecting street drugs, and it's something that's been, you know, sorely lacking. It's actually sitting down with people and doing that visual inspection frequently. Okay. Okay, so we ask clients if after injection they flush their needle and syringe out in water. You can see over 42% said that they did that. Now that shows that the only reason you would flush out your needle and syringe after injection is if you plan to reuse that. So we can see a lot of needle reuse there as well. And of course, this ties in well with things like you know, bacterial infections, which were common as well. Over 16% of clients didn't have full control over the preparation of their drugs. Someone else prepared their drugs. And of course, there's a real risk there for the transmission of bloodborne viruses if that needle and syringe or paraphernalia has been previously used by someone else. Something that I guess the most concerning thing for me that they jumped to this was the nearly 20% of clients that reported the direct sharing of needles and syringes. It's just so high. Now, bear in mind that the backdrop here is, an outbreak HIV within this area, within this population, and we've been shouting from the rooftops, share nothing. We have no limits in the amount of equipment that people can give out. We've got fantastic coverage across the area. Yeah, 20% of people reported they were still directly sharing needles and syringes. Now we know this is likely to be underreported because there's a real stigma surrounding reporting that you directly sharing a needle and syringe, and you can see that the sharing of paraphernalia was even more common, over 30%. Okay, other concerns. Over half those clients that we assessed had not been tested for a bloodborne virus in the previous 6 months, and well over half were unaware of the current status. And you can see we identified new cases of HIV and new cases of active hepatitis C infection. And because we have such a large HIV positive population within the city centre, then after a week we chose to stop BBV testing any person we were assessing and were aware of their HIV status, because it triggered a whole fail-safe process when there was no need for that. Okay. Some real positives come out as well. You can see over 61% of clients have been given or prescribed naloxone in the previous year. Unfortunately, only 20% of them were actually carrying it with them at the time of assessment. And of course, what we try to do is encourage people to take naloxone, but also carry it with them. So when they come in another 3 months for the next round of wand, all they have to do is show us their naloxone, and we're able to take that off. So training, if you like. They're quite concerned that a third had overdosed in the previous 12 months, and every person that said they had overdosed had naloxone administered. And I think what that tells us is, for this group anyway that we assessed, they only think an overdose is an overdose if they actually have to be brought round with naloxone. But of course, losing any state of consciousness could be described as an overdose and an opportunity to intervene. And you can see there less than a quarter actually had naloxone available at the places they prepared and injected their drugs. Okay, so just to round off, now I can only speak for Glasgow City here. Our core harm reduction interventions, such as wound care, such as assessment, injecting risk, the provision of naloxone and dry blood spot testing, were not routinely offered and not offered to the level that we would want or we would expect. Services were initially a little bit reluctant to buy into this process, and particularly as they started to see footfall increased. In the first week there was a bit of resistance, but I think it's fair to say that changed fairly quickly as staff's confidence and I guess their skills, and particularly in conducting the assessment, increased. I remember a staff had said to me a couple of weeks into it, he went, "You've trained me twice for dry blood spot testing, and I never had the confidence to do this, and this has actually made me do it." And there was our staff getting quite excited about some of the risks and harms that they had identified, and how the person's injecting practice was poor, and they were able to give them advice on that as well. So we're continually picking up high risk injecting practices. Bloodborne virus testing was way below we would expect, and I think for us in Glasgow there has been huge benefits in stripping it back, really getting back to basics and looking at interventions to try and reduce fatal or non-fatal overdose, a whole range of injecting complications, and the provision of bloodborne viruses. Okay.
Well, thank you, John. That was really interesting, and I'd seen the results from the AIR tool before, which, as you know, there are a lot of similarities with the small-scale study from the AIR tool that we've done in Edinburgh, especially around things like flushing and naloxone. But I do want to say thanks because John, you have been pivotal in pushing the AIR tool, and I remember at some of those meetings we were all pulling our hair about how do we get this to work, and it is such a sophisticated tool, and it allows us to gather information locally that not only we can get snapshots of what's going on, but we can actually provide real interventions at that point of contact as well. So great work, and hopefully we'll see it spread across the country and we can look at that information at a more national level. So thanks again, and just a wee bit over time, John, but you're fine. Magdalena, welcome. Can we have you in? Hi.
Hi. Cool. Thanks, Jim. Thanks, everybody. It was really great to hear Andy and John, and actually I'm going to be picking up on quite a few things that they said and providing perhaps slightly different context to them. So next slide, please. So I've been asked to talk about the ancillary benefits of IEP, and I'm not going to concentrate completely on this, and perhaps some of the ancillary benefits will come through and some of the other things I'm saying, because I'm hoping that we all know about the ancillary benefits. Andy said, IEP is not just about injecting equipment provision or bloodborne virus prevention, and I hadn't seen the slides, but there's a lot of nice crossover between mine and his and John's. And traditionally IEP is funded on a bloodborne virus prevention remit, but it can offer so much more. Important connection to health and social care supports for a very marginalised population, best practice harm reduction and tailored injecting advice like John was talking about, wound care, Hep C testing and treatment, as we've seen in some IEP services in Tayside, for example, skin and soft tissue infection prevention. But really importantly, provision of these services in a non-judgmental setting is really important for reducing shame amongst a really stigmatised population. I think shame is quite key to preventing health harms and putting a dent into what can be some quite self-destructive patterns. So next slide, please. So we cannot take it for granted that all these services are automatically provided in needle and syringe programs and IEP. Some providers only offer a transaction in pharmacies, for example, and this is why I think it's fantastic that the guidelines have really emphasised a wide range of IEP providers. So this participant in one of my studies talks about a pharmacist asking if anyone had given him harm minimisation advice. He says no. She says, all right, we'll just tick the box now. So standing there waiting on the harm min advice, nobody gave it. It was just a tick box, and often it's not even that. It's just a transaction. Now, it's really important to note this because we cannot assume community transmission of safe injecting information, and this is why the NEO thing that John talked about is absolutely fantastic. I'm really pleased to hear about that. And so here we have this participant saying, no one told us, we didn't hang around with other heroin addicts to learn from, we didn't know how to inject properly, our veins were fucked really quick, went to a chemist, can we get some ones? We've only got twos. They're like, yeah, whatever, it doesn't matter, it messed up our veins. And I think thinking about vein care is really fundamental in terms of reducing health harms, and I'm going to talk a little bit more about that as well. And we cannot assume non-judgmental provision of injecting or skin and soft tissue infection advice, and this really comes across to me as a researcher where people identify me as perhaps someone that they can trust, and then they will often ask me. One of these participants, she would often on 2 occasions whip down her pants and point to her femoral injecting hole and say, am I going in the right place? And would tell me that she didn't feel that there was anyone else that she could ask. Now I'm not a medical expert. It's not my place to be able to provide that advice, but it really showed the lack out there at that time. Next slide, please. So for these reasons and more, I really want to commend the good practice guidelines, and I've read them thoroughly. They're fantastic, and you know, I want to say how wonderful it is to see that they're addressing access through detailing a broad range of injecting equipment providers, addressing coverage, emphasising no limits on equipment provision, addressing reuse through comprehensive equipment cleaning advice, addressing inequity, and you know, in multiple ways, but the inclusion of water for injection here is a core example. Addressing skin and soft tissue infections through attention to wound care and injecting practice, and pushing the boundaries beyond current legislative limits. And I'm going to talk about that in relation to crackpot use. Next slide, please. So Andy mentioned coverage, and I just want to raise this, and I know it's not what I was asked to talk about, but I think it's absolutely fundamental if we're going to think about IEP in relation to what is coverage, how is it measured, and what are the assumptions that it's based on. So the NECE guidelines here, which is cited in the guidelines, say needle and syringe provision is considered adequate when the reported number of needles received meets or exceeds the number of times the individual injects. And as we've heard, this is suboptimal. But you know, not often. How are coverage estimates made, and what are the assumptions that they're made under? So if you have a look at the Harm Reduction Works coverage calculator, for example, it's made for local authorities or commissioners to work out if their coverage is adequate. You know, they put in the number of people who inject drugs in the locality and estimate how many needles and syringes are required. And some figures are provided here. For example, not on opiate substitution therapy, there's an estimate that they'll be undertaking 3 injections per day, and on opiate substitution therapy, it's about 3 injections per week. Next slide, please. And I think we really need to interrogate these. We particularly need to interrogate these in relation to the Scottish data around the rise of cocaine injection, whereas people are going to be injecting a lot more frequently. But also in relation to assumptions about how much people inject when they're on OST. So my study with people who inject drugs in London, for example, showed that there was very little difference between people who are on OST and people who weren't on it in relation to injecting frequency. People on OST inject 63% reported injecting once or more a day, and not on OST it was 65%, and 65% of them of the total reuse their needles and syringes, which speaks to an adequate coverage. And in the SHBBV guidelines, as others have said in this presentation, you know, really note an increase in reuse that needs to be addressed. Next slide, please. So I think what we also need to think about when we want to address reuse and the assumptions that underline coverage is how many needles and syringes are required per injection. And there's often an assumption that providing one needle and syringe per injection is adequate. But what we can see from the Cure and Prevent study data is that nearly a quarter of the 455 participants reported taking 4 or more injection attempts. So 4 or more skin punctures to try and achieve an injection. And this speaks to you know, really serious peripheral vein damage. We have 32% reporting injecting in the femoral vein, and I think the majority of these will be the ones that say they get it once off. So there's multiple risks here. The quotes below talk about increased blood in the environment through trying to inject multiple times, but also point to the fact that they're going to be reusing syringes. They're talking about the blood congealing, emptying it out, recooking it. People talk to using up to 7 syringes per injection. So if you think perhaps that people who are using cocaine may be injecting 10 times a day, they may be going through, might be going through 50 or so needles and syringes a day. So no wonder people are reusing. And I guess that I'm giving these examples, even though they're sort of not exactly on ancillary benefits, because I really want to stress the importance of getting as many needles and syringes out there as possible through as many means as we can, and particularly in relation to cocaine injection, and to really think about what we base our coverage calculations on. Next slide, please. I'm not going to go over this, but just in relation to skin and soft tissue infections, I think what's great about the guidance is that it emphasises wound care, and I think also that we need to be mindful that a lot of people would like support to care for their own wounds, and that that people face a lot of barriers to coming to multiple wound care appointments. And the provision of wound care is also really important because it helps people, they feel trusted, they feel like they're being recognised for their own expertise, and that's something that's really come out strongly in my work, and I think can be also a real ancillary benefit of needle and syringe programs, is by providing equipment, by providing training, by recognising people's expertise, people can feel more valued in their lives, and that is absolutely fundamental. Next slide, please. Now, what I was really heartened to see in the guidelines is that water for injection is included as part of the core kit. And this is not the case in the UK. Water for injection is not comprehensively provided in all pharmacy injection packs, for example. And this is really important for a number of reasons. And it's particularly important to include water for injection as a way to acknowledge and address inequity. So my recent study, the majority of participants had a lifetime history of street homelessness, with 46% currently on the street or living in a hostel. And what was notable was the difficulty that people had accessing clean water for their injection. So people talked about using tap water, bottled water, puddled water, surface water on cars, water from toilet cistern, whiskey, beer, cider, Coca-Cola, lemon juice and saliva to prepare their injections with. And this, for me, I didn't find much that came out of the study surprising, but for me this was, and really poignant, that people were reduced to using their own saliva and puddle water to prepare injections with, and as Eddie said, and this is not only it's not only shameful for people or difficult for people, or people may feel it degrading. And again, that's another ancillary benefit of IEP, is providing people with a sense of self-esteem, at least they're getting the decent equipment that they need. But it's fundamental in reducing health harms. So Eddie here talks about there being no water around, and that he had to use a bit of his own saliva to prepare his injection with, and he got the worst infection of his life. He nearly died. He was in hospital for 3 months because, as you know, there's a lot of bacteria in saliva. Next slide, please. So I'm not going to go over these slides, but they just look. We had a long conversation about what were all the different risks of alternatives to water in relation to health harms, and we've written a paper about this so you can see them. Next slide, please. But definitely saliva and lemon juice are particularly harmful, and this is why water for injection, is so fundamental to be provided, particularly with public toilet closures, impacts of austerity, growing amount of people street homeless. Next slide, please. So what I'm also delighted to see in the guidelines is mention of crackpot provision, and this has been a bit of a passion of mine and lately, because there are so little for people who smoke crack in relation to service provision. And it was interesting that John said that there are about 10% of people that they were seeing who reported smoking crack, but the huge increase in injecting cocaine, perhaps that could be ameliorated by people freebasing their cocaine and then smoking it as crack. So next slide. So I've written about this in this paper in International Journal of Drug Policy, and I can send anyone who wants a link, or you can just look it up. But it's based on study findings from our Cure and Prevent study, where we were concentrating on people who injected. We weren't focusing on crack smoking, but most people were injecting heroin with crack, or they were injecting heroin and smoking crack. And there was a high percentage of people who had diagnosed COPD and real respiratory problems. And I think this is a massive underdiagnosis of COPD, actually. So there are common reports of respiratory problems in the qualitative evidence. And also people talked a lot about using homemade and unsafe pipes. So for example, people using plastic bottles, people using tin cans, people using old asthma inhalers, etc. And so using these implements is going to increase respiratory problems because people are going to be breathing in fumes. It can cuts and burns on the lips through using materials that aren't heat resistant, or sharp tin cans, for example, which can not only increase then that can increase infection and also viral transmission if people are sharing pipes. So I think particularly in relation to COVID, it felt like there's a real urgent impetus to provide crack pipes for people, and that this can reduce respiratory problems, it can reduce viral transmission, COVID transmission, reduce acute injuries, but really importantly, attract disengaged people who use drugs to services. And in the Scottish context, I think it's fundamental to think about in relation to engaging with people who are injecting cocaine and seeing if there are alternatives to that, and maybe in relation to freebasing their cocaine and smoking it. I mean, this has risks as well, but we need to reduce high intensity, high frequency injection in relation to cocaine use, because it has a myriad of health harms. So I think, next slide. I think that's about it from me, actually. And I'm happy to talk about anything else later or in the questions, but the guidelines are great, and they say, they're so comprehensive, and they, one of the quotes in there is that IEP services should not operate in isolation, but in the context of comprehensive harm reduction strategy. And this is absolutely crucial, and is particularly crucial in relation to the increase of drug-related deaths in Scotland. There is an urgent impetus to act here and to engage a highly disengaged and marginalised populations. So, and I think just important to know also that it's great that the guidelines try and push the boundaries a bit by thinking about legislative change in relation to crack pipe provision, but we also need to extend this to increased drug consumption rooms. And to thank you to Peter Crichton for his consumption ban and all his courage on that front. And this is where we need to go next. So thank you.
Thank you very much, Magdalena. It's really interesting to hear your presentation there. I think you just stay on, and I think John and Andy will join us alongside Leon for the questions, hopefully, that Leon, you've managed to look at and prepare and summarise.
Yes, I have. Okay, I'll just quickly jump into them then, because we've only got 15 minutes left. So I'll do a question to myself first, which was, because I can take that on. So how soon do you think crack pipes can legally be dispensed? And is Leon looking at the legalities in Scotland or all of the UK? It's in Scotland essentially first at this point, because of the Scottish legal system having some difference to the English one under Section 9A of the Misuse of Drugs Act. But we can potentially get a legal dispensation from the Lord Advocate up here, who can give a letter of comfort that people won't be prosecuted if they distribute equipment through the services. That's the process we're looking at. But if we get that, then that can potentially lead to a change of the section of 9A, and crack pipes could get included there. But that's probably going to be a longer process. But it's interesting, you know, in Ireland, they started distributing crack pipes there, and in one section of Dublin, and what they did was they found that it engaged people, etc. And so they increased the number of services that distributed. They didn't go backwards, and there wasn't a blowback. So, okay, so the next bit is the next question. This set of guidelines has a much larger section devoted to cleaning equipment than the previous ones. What has changed? Are we changing practice?
John, do you want to take that?
No, you know, we're not changing practice. If anything, we're continually reiterating the need for single use. But we were also aware that the experience in the group was aware there are situations where, you know, people may need to clean their injecting equipment, and we felt it was vitally important that if we did discuss this, then we also discussed the only proper recognised technique for that. So, no, continual drive for the single use of everything, but there are high risk situations that occur where for some people that may not always be appropriate.
Okay.
I think it's really important in terms of a recognition of the rates of reuse, and it's a pragmatic strategy. You know, ideally we don't want people to be cleaning, we want people to have, you know, new kit for each hit, but this is obviously not happening. So much better that people are given the right information about cleaning properly.
I've combined a number of questions here. A number of people have put this, but what are the benefits of teaching people how to inject safely? Can we be doing sessions with people to show how to inject safely, how to raise a vein, how to prepare in the most sterile way? Does this happen already? And would it be then worth shifting our message away from risk? And what are the benefits for using sterile IEP in terms of a better experience, less painful, as Magdalena's pointed out in one of her previous papers?
Well, I think John's probably the best person to talk to this, but I just want to say I absolutely agree, and I'm all for emphasising, you know, pleasure and pragmatics, and you know, that people can get a much less painful, more enjoyable injection, but also that teaching safe injecting is fundamental. You know, it's going to prevent a lot of health harms, and damage to peripheral veins is causing transitions to groin injecting, as subcutaneous injecting, skin and soft tissue infections, and we cannot assume that people just automatically know best practice. They don't. Not necessarily, you know.
John, do you want to add anything to that?
Absolutely. That was essentially why the assessment injecting risk was developed. I think if we're honest about it, then we really haven't, you know, spoke to injectors as in depth as we should have over the years. You know, I certainly know in Glasgow, you know, historically we've often viewed the people that inject drugs as the experts. They're not. The range of injecting related complications and injuries what we're seeing shows that. But we could start at the most basic level, and if we're not talking to people about how to properly wash your hands and clean your injection site, then we'll not be talking about how much citric to use. And if we're not talking about how much citric to use, we'll not be talking about a suitable choice of water. And if we're not talking about that, we'll not be talking about proper use of tourniquet or the benefits preparing and injecting the drugs in a well-lit, warm environment. We'll not be talking to them then about how to tell if something's went wrong, lumps, bumps and misses, for example. You know, and that is why that assessment was developed. It was to say, look, okay, we've maybe not been having the discussions at a level we should. Here's what we should be asking. Here's how you ask the questions, and this is a process to take you through it.
Yeah, I think there may also be perhaps a training need as well, because I think it's similar across the country in terms of what we're not doing and what we should be doing. But maybe a lot of people feel uneasy sometimes of asking those questions or what the response may be. But Magdalena, I think you touched on the point of a non-judgmental environment where you can ask these questions. And in my experience, and certainly the team here, the clients that are using the service often are happy that someone's asking them more in-depth questions, unless there's the usual "I've got a taxi waiting." But honestly, people do open up when you start that conversation. So yeah, Leon, can we go back to you for any more questions?
There's quite a number, so yep.
Well, can we just bear in mind that of the time, if we're having to stop at 13:45, but.
So this is a question and a statement from this question. So it's is there any work being done with care managers around the use of injecting cocaine? In my experience, there seems to be a huge emphasis on stopping using cocaine before any conversation can take place about greater control over their medication, e.g. 7-day take home. Yet there is no prescribed replacement for cocaine or stimulants widely used. So this is very difficult and not desired. So it's the start is there any work being done with care managers around the use of injecting cocaine, and what could be potentially done there to? Andy,
are you aware of anything?
I mean, you would really need a care manager to reflect that. I think our job is to make people aware of this issue as much as we can, and I think we've done a lot of work over the past few years to really highlight the issues related to cocaine, to quantify them, to narrate them, to make sure that people at all levels, whether at the frontline coalface or whether at the policy level, are fully aware of what's going on here. I think it's reasonable to say that we've been slow to respond to the onset of cocaine injecting across the country, and I don't think many people would disagree with that. And we've seen it started in West Central Scotland, but we've seen it drift right across the country now, and it's evident everywhere. So we do, as a collective group, need to do more on this front, whether at a policy or a practice level. There's interesting points there highlighted about substitute prescribing, for example. The evidence on that is not conclusive yet, but there's some interesting trial information coming out of the Netherlands, for example. But you could argue Scotland's ripe for doing more evidence-based work in this area because we've got such a high concentration of people using the drug. So I think, well, certainly my job as an epidemiologist is just try and characterise that population and illuminate it as much as possible, and then hopefully over time we'll see change on the ground. But yeah, in the defence of care managers, I don't think there's a huge bunch of options for them ready-made to just pick up and address this, because I think it is an under-researched area at the moment.
Thank you.
Okay. Are there any other things that were a bit too controversial to include in the guidelines? And here there's an example of Accuvane, which is probably relevant to the discussion we were having about safer injecting and teaching people how to inject.
John?
Yeah, I don't think that would need specifically covered under the guidelines, but I don't believe that there is anything stopping people, working with that technique at all. If they can buy the machinery to use it, then I don't think they would come up against any opposition. It's something we use in a enhanced drug treatment service for the prescribing of diamorphine.
Okay.
If I could add to that, Leon, I think an important part of these guidelines is that they're not rigid in the evidence. I think we've pushed the boundaries a bit more now, and you can see that they're reflected as good practice guidance, because just absence of evidence doesn't mean evidence of absence, as we all know. And there's lots of learning and intelligence from the ground of things that do work. And I think as a collective group putting the guidance together, we've been quite, I don't know, brave is the right word, but I think it's good that we've kind of pushed those boundaries a bit to get things in there that we think will be beneficial from, certainly, well, not my experience on the ground, but from the individual's experience on the ground doing this work day to day.
Thank you. I think we have time for perhaps one more question, Leon.
Okay, what a very significant question then. Okay. Well, here's a maybe a controversial question. Is there a need for the use of OST or the way in which OST is used to be looked at again, as it appears from figures shown that it isn't making a difference to whether a person is still using drugs, sorry, I need my glasses, or not, is still using drugs or not, as the figures of people on OST and injecting drugs is very similar to those who are not on OST and injecting drugs. So they're essentially saying, is there, with the MAT standards, etc., around that, I think they're saying that, yeah, do we look at the way OST is used? Is there another, do we have to think more creatively about the way that we use OST, I suppose?
Can I come in on that? Because I don't want my figures to be misinterpreted, and just to place some caveats around them. And that this was quite a marginalised group of people who were, majority were in hostel, street homeless, whatever. So, you know, the results need to be taken in relation to that, and that they may be much more likely to be injecting more frequently anyway, and using on top of the opiate substitution therapy, and perhaps falling on and off opiate substitution therapy than perhaps some other people. But I mean, you know, we did see a lot of people injecting on top of their OST, but it doesn't mean that the OST didn't provide any benefit, you know. And I think the last thing I would want is for any of these figures to be interpreted to show that OST doesn't provide benefit. You know, I think what COVID has shown us is that we can be much more flexible in provision, and I think that this is absolutely crucial. You know, I'm not a fan of supervised takeaways at all. I think providing flexibility of provision is empowers people and gives a lot of ancillary benefits, and we've seen some of that evidence throughout the pandemic. I would love to see you know, widespread introduction of heroin-assisted therapy, you know, more options for people to suit their needs. But certainly for me, this does not, this isn't about evidence that it doesn't work, or evidence that we have to, you know, curtail it even more, but the contrary. We need to look at more options for more people, and a lot of those people could probably do very well with heroin-assisted therapy. But also we need to look at pharmacotherapies and better provisions for people who inject cocaine and inject crack cocaine and smoke cocaine. There's nothing for these people, you know. So if you have OST, you may be reducing your heroin injection, but you may still be injecting crack or cocaine, right? So the figures weren't saying what people were injecting, and there needs to be, you know, huge, much more attention and supports for people who use stimulants and inject stimulants.
Okay, any final comments from John or Andy on that?
Yeah, Lee, I think it's really important that, you know, we do work with a population and try and get them to engage with drug services, whether that's OST or not. But we do know then, for those clients that do link in with an OST program, they often inject less. So yeah, they may still be accessing our IEPs, but they're injecting less. We know they then have less chance of experiencing a fatal overdose, and the overall improvements in their health. So it's maybe not just as black and white as saying, well, you know, this person is now receiving ORT, so they should no longer be being injected. And maybe if we're able to work on all those other associated benefits, like their health, like their engagement with services, we're giving them the best opportunity possible at some point for that OST to work.
Okay, that was perhaps a good point to end in, because unfortunately, I think we've come to the end of the webinar, but this has been recorded and will be published on the SDF YouTube channel, I think, as soon as possible. Next week, I think we're hosting 3 consultation workshops on the updated guidance, which I think are already fully booked. but these sessions will be held via Microsoft Teams, and further information on how to access them will be provided on Monday for those who have signed up. If you're unable to secure a place in one of those workshops, you'll be able to give feedback via the guidelines, which will put part of the online survey, I believe, and a link to this will be included in the evaluation, which I'm hoping people will fill in and complete for us, because that's always really useful. So finally, I'd just like to say thanks for everyone who attended the webinar today, and a very special thanks to Magdalena, to John and to Andy for a really interesting and informative discussion. So thanks again, and have a great weekend, everybody.
Cool, thank you. Thanks all.
Cheers.
Bye.